Well, it is my absolute pleasure this morning to introduce Dr. Johanna Scheurer, a member of our Division of Neonatology. She is here today for an education-focused grand rounds. She completed her undergraduate degree at Tufts and then came back to do her medical degree at the University of Minnesota, which is when I had the chance to first meet her. We were lucky enough to convince her to stay here for residency. I got the privilege of working with her closely when she served as a chief resident in our program. She's gone on to complete fellowship in neonatology and now is a really key member of our education teams and our neonatal care team here at the University of Minnesota. She's been recognized as a top doctor and a rising star, both by her peers and in our own department with the Excellence in Teaching Award last year. She's the co-director of the Becoming a Doctor course for our 3rd and 4th year medical students, which is a really neat course that I encourage you to ask her about if you haven't heard about that course before. She directs our medical student experiences and resident experiences in the NICU and serves as an associate program director in the residency program. She also has done additional training through the Academic Pediatric Association in a program called the Educational Scholars Program that allowed her to do some of this work that she's talking about today or provide guidance as she was doing it. So if you have questions about the ESP program, I know she'll be happy to talk to you about it. Numerous papers, numerous abstracts, grant funded, all around superstar. It is just my absolute pleasure to introduce Dr. Scheurer, who will talk to us about building trainee competence in pediatric end-of-life care skills.
Thank you, Dr. Borman-Schoep. Good morning, everyone. It's a pleasure to be here. Disclosures to point out today, Dannell Shu, who I'll introduce in a little bit, is paid for her work as a bereaved parent consultant with our group, and I'll get back to why that's actually really important to us. And we will be discussing pediatric patient death, and I want to acknowledge again how difficult that may be on any day, and particularly difficult today and events yesterday. And though it's maybe also somewhat timely as a reminder that tragedy can strike families and their children at any time, and it's important for all of us as providers caring for children and their families to have competence in this area. Here are our objectives today. I will start off with some definitions to make sure we're all on the same page. We want to explain the role of bereaved parent educators in pediatric end-of-life care skills training. That is really a somewhat more unique feature of our curricula we have developed. I'll describe what a deliberate practice model is or framework for medical education and how it really has been important for our communication curriculum and can help in other similar things. And I may even be able to help you implement one or more proven approaches to difficult conversations with patients and their families. I would like to let you know that this workshop really was born out of a call for help of a trainee in our department several years ago who approached one of our pediatric palliative care doctors at that time, Dr. Naomi Goloff, sharing some distress they had in being called to provide end-of-life care to a pediatric patient and their family without feeling that they were adequately trained to do so with the level of supervision they were expected to do it at the time. And this was very distressing to the trainee. And they reported having bad dreams about it. And it really, as I said, was a call for action of this being such important care at a time when we really only have one chance to get right the care we provide for a dying baby, child, or adolescent and their family. So that really got us to start with a vision that we want to, through education of trainees, improve end-of-life care for pediatric patients and their families. And that an important part of that is that not just helping with competence in trainees, but really enhancing their well-being through education that equips them to work through these traumatic clinical situations. I'll go through a couple definitions and then we'll come back to our work on the Pediatric End-of-Life Care Skills Workshop. Pediatric palliative care is defined by the World Health Organization as active total care of the child's body, mind, and spirit, and also involves giving support to a family. And really, it's a model of care with the goal to improve quality of life for infants, children, or adolescents with serious illness and their families. It doesn't necessarily have to be life-limiting illness, but serious or complex illness. And it focuses on easing symptoms and stress of the illness, so pain and symptom management, and the communication that's required to help families discover their goals and values and decide things together. Psychosocial support is important to it, and really attending to emotional, social, and spiritual needs of a child and their family. And so this is a nice continuum of what all is palliative care, and it's this whole continuum here is part of palliative care. And really families receiving palliative care, there may be a focus of cure of disease, life extension, a miracle, while simultaneously being hope for comfort in their child and family's life and meaning from what this illness means for their family. Pediatric end-of-life care is considered a more distinct period of care, though is often delivered within palliative care frameworks, but there's more focus on comfort and less focus on cure, life extension, or miracle, but not necessarily no focus on that at that time. The distinct period of time, as many of us know in pediatrics, an end-of-life period can be moments to weeks, and depending on disease course and things that we do and don't understand can be unpredictable as well. Symptom management during this time is specifically focused on symptoms of dying for the most part. So here is end-of-life care within that whole continuum, and I'll mention again that it is also within palliative care. The final definition is pediatric hospice care. Some people wonder what the difference between palliative care and hospice care is. Really, it is care with the same goals and overall model as palliative care, but refers to specific services for pediatric patients with a life-limiting diagnosis, where there is a prognosis that death is likely within 6 months. Certainly, as I mentioned, we don't always know how long a baby, child, or adolescent with a life-limiting condition will live, but it's a prediction. And importantly, in the United States, hospice care can be provided concurrently with life-sustaining interventions. So again, back to this continuum, I like to think of hospice care as, again, all-encompassing of this continuum, and it's the services available when death may be within 6 months. And again, to mention that concurrent life-sustaining therapies such as tracheostomy and mechanical ventilation can be provided within this when that aligns with the family's goals and values at that time. So to talk now about our workshop, our Pediatric End-of-Life Care Skills Workshop, I'm going to go through a paper our group has written. It's under review right now, going through how we really developed this workshop and what we have learned and how we have built upon it and expanded it. Much like in lab science, you do methods, results, and a discussion. In education, there are various frameworks to go about that. I'm going to show you a 6-step approach of curriculum development and evaluation set forth by Kern. So we'll go through each of these 6 steps to talk about our workshop. The first piece is the problem identification, which I already spoke a little bit about, but really the need for end-of-life education, especially as medical care for children has advanced in the past decades, and children are increasingly living with complex and chronic conditions. Yet despite the progress, tens of thousands of children die in the United States each year, and of course more worldwide. There are quite vast pediatric palliative care curricula, but a lot is focused on either didactic, kind of lecture-based learning, or the assumption that learning takes place in observing others, mastery learning, observing that experienced clinician, attending doctor, which is certainly a very important piece of education in this area. However, that really assumes that the opportunities to observe someone in this area will occur, but end-of-life care is not quite so discrete, for example, as the beginning, middle, and end of a well child check. And it's also not on a schedule most of the time. And such as a surgery resident knows that a G-tube surgery is scheduled. We can't necessarily say that everyone will see this in the clinical learning environment. And so additional education is needed. Back to the fellow who had the call for help in this area, as we really started to think about it more, we considered how in pediatric critical care providers are required to maintain certification in pediatric advanced life support, regardless of if they have run one or many codes in the last 2 years. They need to continue to practice in the certification and demonstrate that they remain competent. That the same is true in my specialty, neonatology and neonatal resuscitation program. Similar training is not available or required for end-of-life care skills. Really, again, can be quite distressing to a trainee who is working with families at one of the hardest times of their lives, and needs to have some skills to help that family get through that, and again, feel okay about what they're doing, and really be able to get to a place of sitting with families in those more difficult, grimacing moments of the previous pictures, and helping families get to a place of comfort at those moments as possible. The next step in developing a workshop is a kind of more targeted needs assessment and thinking about what is out there. Did we need to design something completely new? Was there something we could completely borrow from someone else who had developed it? And so I'll just mention a couple of things that have been helpful to us. A couple people who have worked locally, but part of a national work group in developing pediatric primary palliative care education, which is the idea that not all palliative care is delivered by palliative care specialists. It's how you get someone like a neonatologist giving this talk today, and that there really are some skills that many pediatric providers, from primary care to multiple subspecialties, need to harness at times. Catherine Brock at Emory has developed quite a extensive palliative care training that's both didactic and simulation. And we were quite certain we wanted, as I started mentioning, that experience outside of the clinical learning environment. This has been helpful, but is less specific to end-of-life care. Some of that is there. And then also in Michigan, they have a training program for health professionals among not just doctors, but among in the interprofessional team, specific to end-of-life training, though that is much more didactic based from my understanding. So those are just a few things we drew from. And then the next step is really to hone in further on specific goals and objectives. And for that, we really wanted to make sure that trainees have practice and are able to improve their self-efficacy. That's another word for confidence in areas that are defined by the hospice and palliative medicine milestones or competencies, and the ones that are specific to end-of-life care and found in some of our pediatric subspecialty competencies too. And that these competencies are related to a lot of communication skills, both with patients, families, and the team, but also related to patient and family care, such as performing an extubation at the end of life, and medical knowledge, such as principles of pain and symptom management specific to this period of time. Notably, all of these require work among a large interprofessional team, which has been at the core of our planning from the early phases. And so we really see that pediatric end-of-life care skills are best with a team, which includes doctors, nurses, spiritual health, social work, child family life, and many others that I could name. And really at the center of this is the patient and family. So as we really got into thinking about the importance of centering the patient and family in this work, it became clear that we needed to find ways to have this voice in planning that curriculum. So it's now my true pleasure and honor to be able to introduce Dannell Shu to you. She is one of our bereaved parent faculty, and we are so fortunate to have her locally because she does work in this area now nationally on National Palliative Task Force and in our state, and really the education she does with us is a small piece of all of the advocacy work she does related to pediatric palliative care, and is really honoring a great legacy of her son, Levi. So I will turn it over to Dannell now.
Good morning. Thank you for gathering today. And I also want to honor the sacredness of today and honor you as providers of our children here in Minnesota and to wherever you may go. Thank you for the work that you're doing and for, on a particularly difficult day, showing up to this grand rounds. My name is Dannell, and I am also known as Levi's mom. You'll see pictures of him there on the left. Levi was born with severe brain damage, HIE, and we were given an initial prognosis of hours to days. And Levi's an example of how palliative care and the unknowns of where a child's life will go and the trajectory come together in a really unique way. With Levi, we did a compassionate extubation at 1 week of age. And to all of our surprise, he was able to breathe on his own. And so we began the journey. Thankfully, we were given a palliative care referral and was able to come home at 3 weeks of age. And Levi, as you can see by the pictures, lived quite a while. He lived old enough to be a big brother and was 7 years old when he passed, which was 5 years ago. My co-partner in this work is Kelly McMahon, who wasn't able to be here today. Her daughter, Charlotte, nicknamed Charlie Girl, was diagnosed at 6 days old with an AV canal hypoplastic left heart syndrome. She spent a lot of time in the hospital. She had 3 significant heart surgeries, and her life was 4 months and 3 weeks old. Kelly is also a social worker by trade, and so her and I bring a unique set of skills as parent advocates and parent educators. Interestingly, our introduction into this work was simply an invitation. It was an invitation by Dr. Goloff at the very first workshop to say, I know I need the family voice in the midst of this. I know that this needs to be family-centered care and family-centered education. So she just simply invited us to come and observe, and let's figure out together how to bring the parent voice into this. And by the end of the first workshop, Kelly and I were sitting in on the sessions, in as faculty members, observing the simulations, being a part of the conversation for the skills workshop. And right away, we found that the learners, the fellows, were engaging us as parents with their questions. And we recognized together as parents and as faculty the importance of being able to have a safe space where learners and fellows could not only dive into this material and this work and the skills of end of life, but also to have a safe space where they could engage with us as parents and ask those questions that you don't get to ask parents and families who are also your patients. And we've had several years since our children have died, so we have reflection, and we also have a lot of other families that we're in touch with and that we can speak on behalf of. So that's kind of how our introduction into this work began, and I'll share more later on what that looks like within the education.
Thank you, Dannell. We, with the ongoing work of our bereaved parent educators, there is actually literature on this too that I'm just going to briefly mention. A lot, especially at St. Jude, they use bereaved parent volunteers for a lot of things, a whole bereavement program, and including in an educational role. This overall sounds good. It could bring up worries for some people too. What are the downsides of having bereaved parent educators? What are kind of the risks of this? And this last paper was a qualitative interview study of bereaved parent educators and other educators and end-of-life care of different interprofessional team members, and really found some important positive pieces of it, and really that it provides a sense of purpose, not just to the parent educators themselves in honoring their child and helping pay back providers, but also a sense of purpose for the other educators and trainees. Other educators talk about it making it more real to have the parent voice there. Certainly there are challenges. The main thing people talk about being hard is a so-called emotional factor, and that's really how the ongoing grieving process comes up for parents in this role. And so they make a point that that's a challenge, but not one that can't be overcome with how things are planned and how to engage parents in this important work. So back our workshop, so we found our goals and objectives, and the next is to think about, okay, how do we make that into a strategy to deliver some education? And we landed on something called deliberate practice framework that I say is both intuitive, but also something we don't necessarily think about a lot in medical education, where again, a lot of emphasis is on that mastery learning and kind of learning in real-time clinical environment, especially for residents and fellows in graduate medical education. A deliberate practice framework is really thinking about how you need to practice and have coaching and formative feedback, and is really this idea that there's both getting experience and performance improving over time with feedback and coaching, and that some things don't need a lot of that. Learning how to do the dishes or drive a car can over time become associative or autonomous everyday skills, but certain things that require more to it, expertise. There's a steep learning curve at first, and people gain a lot of, do better in their performance just with being in the clinical learning environment. Certainly we see this, but that without the kind of ongoing practice and coaching, you can reach a phase called arrested development and really not be able to get to expert performance that's possible with practice and coaching as how I frame it in my mind. And this is true for things like clinical reasoning and diagnosis, and I think is really pertinent to an area such as end-of-life care skills. Why I say it's intuitive is we think of this, we know this is true for learning an instrument, learning to play chess, many sports, that it takes practice and coaching. This is the first Black female NFL coach, Sarah Thomas. But I would say the same is true for end-of-life care skills. Requires practice and coaching. And so this deliberate framework practice is what we honed in on, and really focused on having experience in the simulation environment with the practice and coaching in the safe space, and that we really, through the workshop, can enhance competence in this area of care in the clinical learning environment. So what does that actually look like in a half-day workshop? Well, we start off with an introduction to the material, pre-briefing that's kind of standard in simulation education, setting psychological safety, suspending disbelief. We do some just-in-time teaching that I will tell you more about. These first two parts of the workshop are a large group format where both the trainee participants and all the facilitators are there. The just-in-time teaching includes a number of different elements. And for example, we give trainees these cards developed by Michigan that go through some titration of medications, planning for a pediatric death, and have guidelines related to specific end-of-life interventions, and really distinguish what non-escalation of life-prolonging therapies versus discontinuation continuing hemodynamic support. I'm not going to go into details of that, but just to share that that's part of the just-in-time teaching and materials we provide. We are going to do a couple brief just-in-time teachings this morning. And the first is that we talk about the importance of silence. And if you're like many doctors, it's difficult to stay silent for more than an average of 11 seconds in a conversation with families. So now Dannell is going to encourage us in a moment of silence.
A lesson that I learned from Levi was, when it comes to silence, wait until you're uncomfortable, count to 10, and then wait again. Many times we have the urge to jump in and speak. And so today I'd like to just guide you in a moment of silence, and notice in this moment of silence if there's a shift of moving from comfort to discomfort. And notice when that arises, and if that does, give yourself the opportunity to quietly inside yourself count to 10. So I invite you, if you've got something in your hands, to set it down. If you're sitting, to place your feet on the floor, and or if you'd like and are able to go ahead and standing with your feet on the floor and your arms relaxed. Let's take a moment to take 2 deep breaths together, and then we'll take a moment of guided silence. Inhale, slow and deep, and exhale, a full, complete exhale. Second breath. Inhale, slow and deep, and exhale, a full, complete exhale. Let's enter a moment of silence, noticing the sounds within you and around you while we're silent. I invite you to open the ears a little more and notice the sounds in the space that you're in, the sounds that might otherwise not be heard. We'll finish this time by taking 2 deep breaths together. Inhale and exhale. Inhale and exhale.
Thank you, Dannell. Another area of just-in-time teaching we spend some time on is talking about the balance of ambiguity and clarity, and that both of these things are present and swirling in and out surrounding end-of-life care, and that it's really important to both be able to say, I don't know, and here's what I will do to find out, or here's what I can't know, but I am with you on this pathway together, along with clarity and not beating around the bush, not using euphemisms, and being able to, when we do know, say something clearly, such as your child is dying. And so we spend a couple of moments in the workshop having everyone say those words out loud. So I invite you now in your space to simply say, your child is dying. Your baby is dying. After our opening part of the workshop, we then break into small groups of 2 to 3 trainees and 2 to 3 facilitators from the interprofessional team, and they go through 2 simulation conversations with trained standardized patients, or SPs we call them, and actually in our workshop they're standardized parents, and these are cases that have been written with help from the interprofessional team surrounding different areas of end-of-life care skills and at the level of the trainees who are at the workshop. They also go through a skills station and do an end-of-life extubation, considering being able to actually perform that from a psychomotor standpoint, along with being able to simultaneously make sure the team is all prepared to turn off the ventilator, turn off monitors, have this be focused on the caregivers and the patient, whether that's getting them holding together, focused on whatever spiritual health needs there are at that time, and communicating among the team with actually a lot of steps that are going on to make that a meaningful time and comfortable time. This is a picture showing one of our simulated hospital rooms. In this scenario, a patient mannequin is present, and you can see our standardized patient caregivers there, and 3 trainees and interprofessional facilitators. Here's a doctor, Dannell, one of our parent facilitators, and a nurse. During the scenarios, the facilitators are observing behind these windows, so the trainees and parents are doing it in real time, and then everyone comes back together. The standardized parents and the facilitators work to fill out a checklist with some different areas of end-of-life care to think about how well the trainees are doing it, and then come together and do this feedback and coaching. And it's really interesting throughout a half-day workshop that there's iterative learning going on, and what they learn in one part they apply to the next part. Then after those stations, we come back together in the large group for a final debriefing. And again, that is focused on thinking about engaging and communicating with the interprofessional team, including the parents. Dannell and Kelly answer a lot of questions often during that time. We start to think about how this can be applied to the clinical learning environment. And we spend time really considering that this is difficult care to provide for our skills, for our emotions, and think about how to support ourselves and one another in providing this care and remaining a really whole and well physician, able to continue caring for other patients like this, or patients who have other needs, and able to be whole and well people outside of our profession as well. The implementation, the programs we have included over time are first kind of pilot workshops, which we have done a lot of program evaluation about, reached 33 trainees in neonatology, pediatric critical care, hem-onc, and BMT. We have developed an ongoing model, thanks to support from fellowship directors in the department, where we offer in these 3-year programs, we offer the workshop in years 1 and 3. So early in training, and then the trainees do a lot of work, of course, in the clinical environment, and then come back in their 3rd year and really build on that and hone in on that. And then we also offer it once to BMT and hospital medicine, those 1 to 2-year programs. We just in the last month piloted our first interprofessional workshop. We had 9 trainees, and these are earlier trainees and interprofessional trainees. So pediatrics residents, graduate social work and nurse practitioner students, and an early career social worker. And that was great. And I'll say more about that in a few minutes. The facilitators, again, as I keep mentioning the interprofessional team, our facilitators come from the interprofessional team, and that's been important to us. And again, centering on the patient and family, Dannell will tell you a bit more about what her role looks like with the workshops themselves. You are muted still, Dannell.
Thank you. We began this work with the foundational work that was done in pediatric palliative care over 20 years ago, led by Deborah Dawkin, who was doing involving parent educators in training pediatric palliative care teams. And what was found in that work was involving parent educators at every stage of the curriculum development, the workshop, and the debriefing process. So Callie and I have been involved in the actual creation of the curriculum and the assessment tools for both the current and the new interprofessional versions of this training. We are involved in the training of the standardized patients. So the individuals that are selected by the simulation center to be parents in the simulation. Kelly and I, as bereaved parents, are not the standardized patients. That's something for emotional safety for us that we've been very clear that that's not an appropriate place for us to be. That our role is to be sitting alongside the faculty educators. So as Doctor mentioned, we are behind the glass wall in the simulations, observing, looking at some of the same checklists and evaluation methods that a nurse, a social worker, a physician is looking at. And then we're a part of that feedback conversation after that, the simulation. If we are in the skills training workshop, we're sitting right alongside the faculty, engaging in the conversation, bringing up points about, how would you set this up if you're doing a compassionate extubation? Have you considered A, B, and C, and giving that parent perspective so that the focus can really be family-centered care, can really be care that this is the child's last moments of life. And for the providers to understand that they're an important part of this last moment, that it is a valuable, sacred thing to be a part of a child's last moments of life and to be a part of that care team. And to support providers in the skills, but also the emotional understanding that the families want that support, and then how to be flexible when families express different kinds of needs at that time. And we're also, it's very intentional how Kelly and I are introduced at the very beginning of the training, and made it known that we're available for questions at any points, whether it's in the debriefing or in a break. That the learners and the fellows can approach us and ask questions throughout the learning process. And then we're also involved in reflecting on, after the workshops, how the training went, what modifications can we make, how can we continue to improve the curriculum to serve the learners and to build the resiliency of providers, as well as increase the care for families and children. Thank you.
Thanks, Dannell. I think it's just so great to hear it straight from you, and I hope it gives everyone a sense of why this is so integral to our work. A section on implementation wouldn't be complete without mentioning that funding is certainly required for this work. We need funding to pay the simulation center for space and the standardized patients, training them, and their time on the workshop days. And as I mentioned, it's been important to us to pay the bereaved parent consultants, just as being a facilitator is part of people choose to do it as their role of teaching as faculty. It's important for us to pay people for their time and energy spent on this. And certainly as we are currently working to grow our bereaved parent program, we are really hopeful that being able to pay people for their time and energy spent on this will draw from a larger pool than people who are just able to volunteer for something like this, and hopefully will allow us to draw from a diverse pool of parents and caregivers. A lot of our funding is from a specific University of Minnesota Foundation fund, the Zoya Palliative Care Memorial Fund. Zoya was a patient in our health system, and her family set up this fund specific to palliative care education in our health system. So we're very fortunate to have that ongoing support for our fellows workshops. And then we currently have an academic investment education program catalyst grant to expand the curriculum, which I'll mention in a moment. So what have we learned? Is this effective? Is it doing what we want? The final step is evaluation and feedback. And I will briefly mention some learner outcomes from our fellows workshops. This is Kirkpatrick's hierarchies of learner outcomes, with the lower level being kind of the easier to attain outcomes. So reaction, how participants feel about the training. And at that level, we consistently have evaluations that show positive perceptions of the workshop from the fellows. And really, we highlight this, though it's a so-called low level of an outcome, that it's a positive experience despite the really difficult emotions experience and the hard work it takes. People report it's an appropriate level of challenge, which is important in kind of what scenarios we develop. The next level of outcomes is called learning, and it's being able to measure change in knowledge, skills, or attitudes of participants due to the training. And at this level, we have analyzed self-efficacy, confidence that has increased from before to after the workshop for 9 of 9 items about confidence in various aspects of end-of-life care. And 8 of 9 of those were significant increases. Our facilitators do evaluations, and they also report what the trainees have learned, along with the assessment tool I started to mention. The next level is behavior. So really showing that the training impacts then performance in the clinical environment. And this includes qualitative evaluation data from trainees, and also anecdotes we receive. I have gotten more than one message from a trainee. Thank you so much for this workshop. When I was taking care of this patient recently, I definitely used the skills I learned there, and I know that they experienced better care at the end of their life, and I felt able to provide that. We've done some follow-up surveys and a focus group project that I will briefly mention. This is 3 months after a workshop. We followed up with 18 participants, and you can see we asked them to state their agreement with overall confidence about their ability to provide end-of-life care to patients. And some of them, even before the workshop, agree they're confident in that, but many, this purple, is disagreed. Right after the workshop, we see more agreement and some strong agreement with the statement and less disagreement. And then 3 months later, this confidence was sustained. We held focus groups with 12 trainees, and they reported multiple areas of how the workshop had implications on their clinical practice. The final highest outcome level we talk about is being able to measure change in patient outcome due to training. And this is quite a difficult outcome to be able to measure. So if you have ideas, please share them with me. I would share with you that we have received unsolicited feedback from some of you probably about how a trainee they were working with did an excellent job providing end-of-life care to a pediatric patient and their family, and that when they say, oh, how did you do so well on that, people save things from the workshop. So again, we haven't figured out a great way to formally measure that. We haven't figured out how to formally measure what we're doing and helping people work through the emotional side of this, but we have early findings. Ongoing and future work, where I mentioned our assessment tool a little bit. We have more work on that and eventually hope to have a tool that can be used in the clinical learning environment. We ran our first interprofessional workshop and are working on helping that be a sustainable model, which is no small feat, working with 3 different professional programs with busy schedules. Part of that, what's important to that is expanding our bereaved parent program. We have a collaboration website that I invite any of you to visit. Thank you for being here this morning. I hope we were able to achieve these objectives for many of you. As with any large project, it requires a vast team. So here are my acknowledgements about all the other team members who have helped make this possible, all the participants for being willing to be part of this education, and their leadership who have made the time, and their attendings who let them be away from the clinical space to do this workshop. Our simulation center, couldn't do it without them, and our funding, of course, too. That is what we have prepared, and we will be happy to take any questions or discussion at this time.
Well, thank you both so much for such an excellent overview, both of your talk and of curriculum development. We did have a comment from Emily Lansford, who says, as an individual that participated as a facilitator in the most recent training, it was phenomenal learning for all involved. Would highly recommend residents, fellows, medical students, NP, RN, social workers, learners of all types participate if given the opportunity. I guess I have a sort of curriculum development question for you, Dr. Scheurer. You know, usually along the way you learn some things. Are there things you wish you would have done when you were starting out that you would give as general advice to another faculty member who's working on designing a curriculum or a simulation?
Yeah, I think as much as you can design the project with the end in sight, and thinking about how are we going to be able to report our outcomes and then be able to disseminate and share and hopefully have our curriculum adapted elsewhere. It's challenging to figure out how to get those outcomes at the different levels of the hierarchy and design surveys the correct way. So I think just as much as people can think about that early on, so that you're not just designing excellent curriculum, but that you are designing a way to know that it's excellent with those outcomes.
And I guess, Dannell, I would just invite you to, well, let's see, somebody just has put a question in the chat. Let me find it. Oh, it's also for you from Dr. Ademili, one of our HEMOC fellows. Is there a recommended timeline for bereaved parents in terms of how long after the loss of their child to participate in this type of education?
The general guidelines have been 1 to 2 years. Some programs feel that 1 year is enough time, some programs 2. It also kind of depends on where the parent is in their grief journey. So it's both an individual and a broad response to that question.
Yeah, it is appropriate to many of the things we've already talked about, but I think having some of those general guidelines about, this would be too soon. I think I could imagine someone wanting to get involved or give back, but it might be too early, and finding ways to stay connected with that family and give them opportunities down the road when it's the right time on their journey. Thanks for that question.
Yeah, as we're developing the bereaved parent program, Kelly and I are looking at best practices across the country that are already in existence. And that includes a process for kind of applying and screening parents into this particular work, as well as advocacy work, and following those best practices so that we can incorporate those and bring parents in who are at a place in their journey that are ready to do it. Many of them are ready and willing. So I would say if you have a place where you can bring a bereaved parent in, to invite them in and work through a process, and also reach out to either of the co-investigators in this work and ask from a provider perspective as well.
Great, thank you so much. Well, we are at time. Thank you again for this outstanding talk, and we will see everyone again next week. Bye.
Bye.
Bye. Thank you.